One being, I know you talked a lot about it, but I just really want to emphasize. So why is it so important to have the neuro intensivist experience versus having a general intensivist experience? And the reason why I ask that is every hospital is not part of an academic health system. Every hospital does not have a dedicated ICU for its specific patient populations. And so I think that as we talk about virtual and we talk about layering on additional expertise, I really want you to hone in on that for the many who are participating in today's conference who are not part of Methodist and part of a large system.
Sure. No, that's an excellent question. So I think the idea here is to provide quality of care. And the way you do that is training specific. So if you're in a virtual ICU mode or neurocritical care mode, you're specific in neuro care. You're able to detect changes in neuro exams. And all intensivists, of course, were trained in airway and line management, those things. But it's very important when patients come in with subarachnoid hemorrhage, when patients come in with post-TPA bleeds, how to actually and efficiently manage these patients. You don't want to drop their blood pressure too much, right? You want to make sure that they're not having issues like subclinical seizures. And I think that's where it's so important to understand, hey, what can actually happen? It's through the experience, it's through the training that makes this very important for the quality of our patients.
Thank you. The other question that I have is you talked a lot about scaling and how you plan to do that within the Houston Methodist system. But again, for those that are really listening in and participating who are outside of the system and perhaps living in places which are outside of large cities, is this really scalable in terms of going above and beyond really the boundaries of just distance?
No, I definitely think it does. So you can imagine, though, if we talk about the satellite Methodist, for instance, though, the patient that I presented where she came in with a hypertensive bleed, we're not so concerned that anything else will likely happen if good blood pressure control is obtained, if good medical care is obtained. I don't think it really matters so much how far that patient really is, as long as you have that good communication with our telemedicine experts, our virtual intensivists, if you will, with the hospice or with the ICU physician over there that's taking care of the patient. As long as that line of communication is established, I think the care will be just fine.
Excellent.
I actually have a question for Dr. Nguyen also. With my experience being on telestroke, and certainly I know you can appreciate that being at the physical bedside isn't exactly the same as being virtual. Certainly we are trying to extend ourselves and extend to our patients that expertise and care. Talk about any challenges virtual ICU docs or any other providers maybe have disclosed or commented about some of the challenges of being just virtual and not actually being able to be at the bedside to touch the patient and that experience.
No, that's a great question. So I think it comes down to comfort and also letting go of some of the things that you're used to. The component of this is, as physicians, we like to be hands-on. We like to be able to touch our patients. We like to be able to do our own physical exam. So it does take a component of trust. It does definitely take training by the nurses or whoever's on the other side of the camera helping you with your neurologic exam. So if you're able to have that, again, that communication, have that trust component, I think that makes all the anxiety, if you will, kind of go. And to that, though, there are some other challenges with this as well. The challenge, of course, is how do we not stretch ourselves so thin, right? How do we roll out in such of a way that we want to emphasize the quality of the care, as I mentioned, though. You want to start smaller scales, of course, and you don't never want to actually tackle on a project that's bigger than you think. So that's where I think starting with our non-neuro ICUs here first, and let's see what challenges we have before actually rolling it out further.
That's great. Well, I very much appreciated the dialogue and the discussion. I want to thank all of our panelists, Dr. Nguyen, Dr. Gildersleeve. I also want to thank Stacy Moy, who I think hopefully have shared our lessons learned here at Houston Methodist, but also will offer some opportunities for all of you to certainly take and continue to grow and develop our thrombectomy and our comprehensive stroke centers, obviously across the country, no less here across our state. Again, I want to thank everyone for participating, and I have the honor of turning it back over to Dr. Volpe, who will share some housekeeping issues. Thank you.